Hello everyone, my name is Shahid Nazir Mohammed, and I'm going to give you an overview on an important subject, uh, 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 surrounding research and inclusion, and this focus is around uh, around chronic kidney disease, or CKD, and I've been very fortunate to have to bring you this audio summary, having been invited by Health Service Research UK to provide a perspective on this subject entity, in keeping with their conference that's taking place this September 2021. I'm going to give an outline of this initially, and then provide an understanding on basis for all of these, for all the different focuses and areas surrounding this audio. This presentation will also be made available on the RPSG, the Renal Patient Support Group educational YouTube channel, as well, and the full slide set will be available on there. In keeping with this remit, I would also like to thank the Health Service Research UK for inviting me to present them on this important topic, this is a Health Service Research UK has a collaboration with the Health Foundation, the King's Fund, and the Nuffield Trust, the organisations together seek to provide focuses on different areas of health and research, wherein there are gaps that need to be bridged, and also offer that opportunity for researchers, academics, and those with detailed backgrounds, and have contributed to areas and focuses around different health areas and disease. The opportunity to provide perspective. So to begin with, I'm going to give you an outline of what I'm going to highlight in this audio. So there's some context around aims and objectives, some background or introduction context, some understanding around culture and perspective, what is known about areas around research and inclusion, patient and public involvement and inclusion, some research aspects that surround this subject, more in an overarching format, and then some understanding around or perspective around some areas of best practice, and then there will be in this slide set there is a list of citations and references that have been used throughout this presentation, where listeners, those listening to the audio, can view the slide set on the again on the RPSG, on the Renal Patient Support Group YouTube educational channel, and on there there will, as part of this slide set, there is a list of references for further reading. To begin with, some aims and objectives. To highlight how important the aims and objectives really are two main focuses. To highlight how important it is for inclusion to bridge areas in language and health literacy for patients for going through the long-term condition chronic kidney disease, or CKD, and to highlight if inclusion through patient and public to highlight if inclusion through patient and public involvement efforts can be helpful and be integrated as part of routine healthcare. And again, this will be providing a CKD perspective. Now, so in line with that, I'm going to give a bit of understanding through an intro. So the UK government has emphasised the importance of improving health outcomes and providing smarter patient-centric care, and that has been highlighted through several sources, and through various paper publications, including one by Petsulis and his team and their team in 2015. Such initiative would be supplementary, or should be supplementary to care that already exists. For example, improving health outcomes and providing smarter patient-centric care through links with electronic patient records, or EPRs. There is now ever more need to improve healthcare integration for people with long-term conditions, and this actually remains as one of the most important challenges facing the NHS, or the National Health Service, and more broadly speaking, in context with broader society. And that's context that's actually come out from a report by the King's Fund in 2013. With advances in point of care and areas around point of care testing, for example, improving care for patients with long-term condition should involve a shift from a reactive or disease-focused or fragmented model of care towards a more proactive, holistic and preventative one, wherein such patients and those going through these long-term conditions are encouraged to actually play a central role and take ownership. And again, that is context that has come out from the King's Fund, a King's Fund report, a King's Fund guidelines, in 2013, and by encouraging education and relating contexts across a range of health disciplines, this would or should actually reduce inequity, increase literacy and language, and improve overall healthcare for the CKD population. So in that context, those who are listening to this audio may have listened to the other presentations that have or the other audios that have come up on the RPSG audio channel here, and know that having where patients have opportunities to take ownership of their health, they also stand to become more empowered, and ultimately that also links to areas of inclusion, as being included, and also being actually drivers in aspects of their healthcare. Now, I want to give some some understanding around culture and perspective around this topic as well. So, the National Institute of Excellence, or NICE, and the KDIGO, the Kidney Disease guideline and outcome guidelines, have outlined certain statistics and epidemiology around chronic kidney disease in various parts of the world, not least in the UK, United Kingdom, and in that order, in that context as well, the renal registry, which is linked with the Renal Association in the UK, also have some updates around epidemiology and statistics. Should listeners want to identify more literature around literature and updates around that particular focus. The focus that the Renal Association have also, and the Renal Registry, also tie into areas of socio-economic perspectives, and obviously the more finite aspects around the condition more specifically. The incidence and rate of CKD in the UK in 2013 increased from 109 parts per million population to 115 parts per million population in 2014. The increase was seen in mainly England, where Scotland had fluctuating rates since 2008, and this incident rate excludes actually Northern Ireland and Wales. In line with that, though, as well, ethnicity was a variable factor on age, wherein the median age for white incidence patients was just over 66 years old, and was 66 and 58 for non-white patients. Sorry, 60, just over 66, and just over 59. So the perspective in the literature will also have a focus on male and female backgrounds as well. But this preliminary understanding is based on age ranges for non-white patients. And now in that line with the literature as well, it is almost since 2 decades. It's been almost 2 decades since the UK published the document, The Expert Patient: A New Approach to Chronic Disease Management for the 21st Century. The intention of that was to provide service users service users and service providers really an understanding and basis of how patients or service users more specifically can lead by example, and being experts in disease management, and that was actually something that came out in the Department of Health in 2001. Although this initiative was published in the UK, in Australia there's a team who identified where expert patients in CKD recognized areas of development related to good quality information, and that's been published by in works by Hughes and their colleagues in 2000 and team in 2018. There was an issue around the provision of appropriate and culturally aware information or understanding and knowing who to contact for help. So one of the biggest issues for some time really, and this is a link or between where there's gaps in inclusion in research, but also more generally in aspects of taking ownership, where patients and professionals actually harness information to actually focus and direct areas of health where it is most important for them and their peers. And that is to say, and where in there, that also means that both patients and professionals can, when there is a level understanding across both focuses, then it can be difficult for professionals to provide guidance and signpost, but also for patients to partake in areas of research, and also to actually navigate aspects of healthcare. So this was especially important in remote communities, limited to who have limited access to healthcare. The inclusion of expert patients or service users is not widely reported in literature, and again that's actually been context in a publication by Hughes and team in 2018. So what else is known? There is the clear hierarchy of occupations established through the growth of hospital medicine is also attributed as a major contributor to commissioning and the dominance of medicine in the structural and cultural isolation of health of the healthcare workforce. And so what this means is that patients, unless they seek to take ownership and are empowered, and there are obviously there are various mechanisms that they may follow through in order to ensure that they are to ensure that they are getting the best out of aspects of healthcare. There has been problems in it has been problematic in approach retrospectively. So, for example, patients would when seeking out specific understanding, for example, they do not automatically go to literature. They may literature even if there is context around their specific disease or health ailment, and in this context where there might be a link with chronic kidney disease, they would there is higher probability that they will seek out information or guidance directly from a clinician in the first instance. And so in that respect, and in that regard, when there are various health professionals that make up the workforce or healthcare workforce, patients with this particular condition are more there's high probability that they will seek out information from the clinicians in the first instance, and actually there are other professionals, health professionals, who can give understanding and a basis and on those particular or specific areas of health, but there is for a long time has been a hierarchy, and that is down to how there is a dominance around areas of commissioning for specific long-term conditions. And this is literature, this is understanding that Nelson and their team in 2015 and Pilmer and their team in 2016 have highlighted. International experience also highlights that in planning for funding for specific long-term conditions, their work by Pilmer in 2016 also confirmed that there are different approaches, and different approaches need to also be explored, and allied health professionals and patient and public involvement when looking at areas around different healthcare workforce, different professionals within the workforce, healthcare workforce and patient and public involvement, focus or research has not really been documented extensively, or at least has not been stratified or explored in detail. When looking at this focus, it's more around health professionals, health where there are evaluations around how different allied health work professionals are interlinked to areas of health and service. So the structural and cultural isolation by clinical care groups is focused on making small but marginal service changes, and that's an important point here, because for areas of health to be aligned in focus around long-term conditions such as chronic kidney disease, then effort involved does not always appear proportionate to improvements in services, and that impedes on patient-reported outcome measures, and where patient-reported outcome measures are important, they don't. They can look, or they can appear disproportionately reported, even when there are really good evidences and positive collaborative efforts to join up areas around patient and public involvement and healthcare workforce, and other positive initiatives. And this has been understanding that comes out from work by Roblin and the team in 2009, and Rydersh actually before that in 2002. So I now want to give an overview really on the more specific areas around patient and public involvement and inclusion. It is known in literature, and there are several papers that listeners can refer to, and I'll highlight them. I've highlighted a few, but I will highlight a few more. But what we know from this specific focus is that online space is important. Online spaces are important. They allow exchange of knowledge, approaches, recommendations, and information which reflect the patient experience, and have been sort of ascertained through a shared decision making, and generally through experiences or lived experiences, and patient participation in making decision is encouraged by healthcare professionals and peer groups, but but from patients there is little practical support obtained, little practical support obtained from health professionals when patients, for example, wherein they may want more specific educational basis for their health, and that's important, more because if a patient is going to have, for example, in context with chronic kidney disease, there's not just the chronic kidney disease. For example, they may have a comorbidity, or it might be that they might have a comorbidity that leads to chronic kidney disease, because it can work both ways, more so in the adult population. It can work the same way in the pediatric population for all intents and purposes, but more generally speaking, when patients, if they're not taking ownership or not empowered by aspects of identifying, understanding, or participating in making decisions, then of course the health that they will receive, or the healthcare that they receive, will ultimately be very it would proceed as being quite one-sided. So access to in line with this, access to the internet by patients has had a positive impact surrounding health trajectory, and that's been documented and highlighted across several papers and publications. Those with more education or higher incomes are also more likely to seek information online, and therein there is kind of a more of an indirect incentive for those who are more educated to an extent to take care to make sure that they are to put it bluntly, functioning at their best, because of the employment, for example, employment and security that surrounds aspects of their health and livelihood. So and therein they might be more routine users of the internet, and using seeking out or identifying information more specific to areas of their health. So that's an important focus around the inclusion aspect. The age, length, and time of since diagnosis and stage of disease are not associated with actually the use of internet by patients, and so that is something actually that does need to be explored. Patients seek out information about a condition, and there is a study actually that indicates that around 94% of parents, for example, seek out information via the internet, and looking and sourcing out baseline information in context, and that's been identified in work by Van Dam and that team in 2017, and they also look at that team also look at work or what can be problematic with regard to identifying clinically relevant context through online portals, or and potentially how that can impede on in the longer term around electronic patient records. So the internet has some beneficial effects, and it has been the case since it came into the public domain post 1995 or around 1995. So it has some beneficial effects to increase patient empowerment, but with that, and that's positive, but that because of the kind and how the different sources of information are out there, that can also lead to patients who might not be as empowered to take and to take ownership, or may have different language or literacy levels, for example, can lead to misinformation. There are websites and other areas on the internet, generally speaking, that can actually cause more harm than good as well. And so what we know is that threads through social media platforms, threads through social media platforms can be helpful to identify clinically and non-clinically relevant context, and it's actually by the way of joined up thinking, PPI and inclusion, where both patients and professionals are actually on these social media platforms at the same time, and to join to bridge those areas up, and in line with that, where ultimately where the professionals can harness that context to be part of the patient's record, so that electronic patient record, so there is a link where there is not just numerical understanding as part of the patient's record, but there is qualitative or a contextualized understanding as part of a patient professional or case scenario. That's very and that would help across areas in focuses on diseases like long-term conditions, like chronic kidney disease, because there are various areas of various areas of health and focuses that in between different stages of the long-term condition, where the patient may have to sort understanding from various different um, uh, members of the workforce and and potentially fellow patients as well. So electronic patient records, or EPRs, they have many advantages, but patient enthusiasm and use have actually been quite variable, and that's been documented by Phelps in 2014. The more successful records have provided information that patients or relatives or carers might also need or need access to, usually and usually that's quite pertinent in the case of long-term conditions and emergencies. Variation in using accessing and using electronic patient records do also relate to cultural factors, and I've sort of alluded to that already, but concerns have been expressed about the if not cultural gaps or differentiations. There are concerns about a digital divide between where language and literacy is concerned, and that's been documented or highlighted in work by Nutbeam in 2000 and 2018, and examples of the chronic the CKD perspective around that, or at least electronic patient records, has been highlighted by work from Stoves and here and that team in 2010. So the and where there is a potential digital divide, that can lead to an impede or or a negative impede, really, in relating to utilization and health outcomes. Whilst clinicians have reported that, for example, consultations with patients have changed because of access to electronic patient records, patients still have questions surrounding the underpinnings of their health, around in where chronic kidney disease is concerned, general nephrology, and also and tying in their specific diagnosis and general health care. And that's been highlighted in work by Sarkar and team in 2010, Mohammed and team in 2020, and also in work by Mohammed and Headley in 2019. CKD patients go through various stages of the healthcare journey, and one team informs of how effective it can be for health professionals to use online spaces to bridge areas of education and multidisciplinary team or healthcare involvement. Work by Mohammed and team highlight that in in 2020, and in linking that involvement with allied health professional, that can also bring in a forefront of accessing evidence-based practice and framework surrounding multidisciplinary team efforts and patient and public involvement efforts through online working or remote working, and areas of science or data and science, albeit the primary focus, the preliminary focus, and the areas that need to be more involved is getting those underpinnings right. So where, for example, multidisciplinary team meetings used to be very much frontline healthcare professionals coming together to discuss a patient case, for example, that would not really include, for example, those professionals who might be who would and can contribute to the knowledge base to provide the frontline or the MDT an understanding from focus around that a patient case from behind the scenes, for example, biomarkers, lab tests and investigations, reference ranges relating to those tests and investigations, that has not that basis still needs to be focused or harnessed, so that there is inclusion on that side. And in line with that, just to add, really, clinical scientists, for example, who might be behind the scenes, they may well be involved in patient case scenarios with frontline clinicians and practitioners, but there are other members of laboratory practice who could also be involved, and that has not really been documented or highlighted. So what needs to happen, or what should best practice really look like, or what should it look like? So understanding health information gaps or educational gaps in patients with CKD or chronic kidney disease require educational support to better understand where patients require educational support to better understand their condition or their long-term condition trajectory. More educational interventions are required to support best practice, and that's been highlighted in work by Zulman and the team in 2014. And that could also be achieved through collaborative working through, for example, through primary care networks. wherein primary care networks look to prompt broader allied health professionals and allied health professional groups to be involved between between health sectors, but more around primary care or at community level, where there is still some fragmentation and also some segregation in aspects of the patient care or patient care pathways. Patients may additionally require supplementary education and advice or guidance to help steer clear of misinformation, and that's been highlighted by Mohammed and team in 2014, 16, 19, and 20. 2014, 16, 19, and 20. This work is really just a summary around research and inclusion and an overview of what best practice could look like or should look like. There is a list of references alongside this audio, and that will be made available on the renal patient support group, RPSG educational, a YouTube educational channel. There are some key some main references that listeners are more than welcome to go over. There's work by Ye and team in 2018, where they where the team look at the relation between patient education, patient empowerment, and patient satisfaction, and that's a cross-sectional comparison study in a journal called Applied Nursing Research, and then there is work by Simmons and team in 2016, where they look at understanding tensions and identifying clinician agreement on improvements to early stage CKD in primary care, and that's a qualitative study, and that was published in the British in an edition of the British Medical Journal, or BMJ. There's work by Mohammed and colleagues in 2020, and there's the work was titled "Is there a need for healthcare scientists and educational support surrounding chronic kidney disease laboratory investigations and tests?" And that's summarizing some data through the renal patient support group, or the RPSG, sorry, and that was published in the journal, Turkish Journal of Nephrology, in 2020, and there is one really informative piece of paper publication by Bingi and colleagues in 2015, where they look at creatinine and point of care testing for the detection and monitoring of chronic kidney disease, they provide a primary care diagnostic technology update, and that's been published in the British Journal of in a British Journal of another a publication in a journal in 2015. There is this presentation slide set has a list of references that and sources that relate back to the context within this presentation, and again will be available on the renal patient support group. So I want to say thank you again to Health Service Research UK, and I want to say thank you to the renal patient support group, the RPSG, for allowing the opportunity to present this overview of this important topic around research and inclusion, and it's a privilege to be able to present this, where the Health Service Research UK is integrating this this year's conference with the Health Foundation, the King's Fund, and the Nuffield Trust. I thank you for listening, and I do hope that you've found this beneficial. Do feel free to follow up any queries with the renal patient support group or the RPSG, who are doing quite a bit of work to bridge areas around health, literacy, and education, but also focusing on areas around different areas of healthcare, to bring about an understanding of research and inclusion. Thank you for your time.